Welcome to my channel. In this video we will discuss multiple myeloma. So multiple myeloma is the malignant proliferation of the plasma cells. The B cells convert into the plasma cells and produce the immunoglobulins. Normally these immunoglobulins are polyclonal immunoglobulins, and these have variety of heavy chains. Now in multiple myeloma, monoclonal immunoglobulins are produced, which means they have single heavy and light chain. What are the clinical features of multiple myeloma? In multiple myeloma, you will see renal failure due to paraprotein deposition in the kidneys, paraprotein deposits, due to high serum calcium because bones are destroyed and calcium is released in the blood, due to infections because of non-functional immunoglobulins, due to use of NSAIDs because in multiple myeloma when bones are fractured, then NSAIDs are used for pain relief, and due to deposition of amyloid you will see renal failure. You will also see spinal cord compression. Spinal cord compression is due to bony collapse because of certain cytokines released from the malignant plasma cells, and as a result the osteoclasts are activated, leading to destruction of the bones, and bony collapse will result in spinal cord compression and also extradural mass. These both result in spinal cord compression. There is hyperviscosity in the blood, due to which there is retinal bleed. Cerebral ischemia means strokes. You will also see heart failure and bruising. So these are due to hyperviscosity. Bone pain and fractures are due to cytokines released from the malignant cells, and as a result osteoclasts are activated and cause bone fractures, and due to these bone fractures calcium is released more and more in the blood, and this calcium causes renal failure. Panda eyes are due to deposition of amyloid and also due to nephrotic syndrome. Investigations. What investigations you will do in multiple myeloma? First you will do CBC and you will see anemia and either pancytopenia. ESR is raised in most of the cases. Serum calcium is raised, as I have told you that bone fractures lead to increased release of calcium in the blood. RFTs are deranged because of various causes, like I have told you here in the renal failure, due to paraprotein deposits, increased serum calcium, infections, NSAIDs used, and amyloid deposition. In urine you will find Bence-Jones proteins. These can also be measured in the serum, but mostly measured in the urine. X-rays show lytic lesions in the bones, and bone marrow biopsy shows plasma cytosis, plasma cells more than 10% in the bone marrow. Now when you have diagnosed this condition, how will you manage? Initially, when there are no end organ features, like there are no features of renal failure or heart failure or ischemic stroke, then you will start encouraging fluid intake. Due to this fluid intake, you will treat renal impairment and hypercalcemia. These two things are treated by encouraging fluid intake. Bisphosphonates are used to treat bony pain and fractures. Allopurinol is used to prevent urate nephropathy. Analgesics are used for bony pains, and plasmapheresis is used because when we want to clear the immunoglobulins from the blood, that is, we want to treat hyperviscosity, then we will use plasmapheresis. Now, what are the chemotherapy options available for this multiple myeloma? MPT in older people. M stands for melphalan plus prednisone plus thalidomide. This triple therapy is mostly used for older people. If person can't tolerate this thalidomide, then we can use lenalidomide instead of this thalidomide. You should remember that thalidomide and lenalidomide, these two are given cautiously in the childbearing woman, and if used, then they should use contraception. When you should start treatment, then there is a paraproteins start falling. Paraproteins start falling, and a time will come when these paraproteins don't fall, and this is known as plateau phase. That here you can treat maximally. Now, when plateau phase has achieved, then you will start lenalidomide maintenance therapy, and it showed promising results in preventing relapses. If you have young patients, then CTD, cyclophosphamide, thalidomide, and dexamethasone are used. Furthermore, in these patients, we do autologous hematopoietic stem cell transplantation. In some patients in which bony pains are not relieved, we do radiotherapy. It also decreases pathological fractures.